So thank you, the organizers, for giving me a chance to present on this topic. So today we're going to look at the salt-sensitive hypertension. This would be the outline of my talk. We'll look at the definition, prevalence of the salt sensitivity, hypertension, mechanisms of salt sensitivity, and some of its clinical implications. I think the two previous speakers have looked at this briefly, that we know that hypertension is pretty prevalent, and approximately 1.3 billion people around the world live with hypertension right now, and it's projected to rise to about 1.5 billion in the year 2025. And you can see the chart there. The prevalence of hypertension varies across the world, and it's the variation of hypertension. You can see Kenya there. The range is estimated between 25 to 29%. Sorry about that. And we know that hypertension not only has genetic preponderance, but has a lot of socioeconomic, social and cultural implications. The Black population tend to have not only higher prevalence of hypertension, but more complications associated with it. Not only in Africa, but also studies coming from North America has replicated the same. In terms of definition of salt-sensitive hypertension, this is variable because different studies, be it clinical trials or even observational trials, have used different definitions. Some of the protocols that have been used have been longitudinal studies. Like in this particular studies, they looked at these patients over a period of time, 6 weeks, 8 weeks, and high sodium load was reduced. Some have defined salt sensitivity as a rise of 3 millimeters of mercury or a decrease of 3 meters of mercury. That is a rise of 3 millimeters of mercury with increased salt intake over a period of time, and a decrease of equivalent magnitude with decreased salt intake. However, there's a lot of debate in literature whether we should be using systolic blood pressure, which we know correlates very well with a lot of end organ damage like stroke, heart failure, myocardial attack, or use mean arterial pressure. So depending on which definition is used, whether using systolic blood pressure or mean arterial pressure, the prevalence or burden of salt sensitivity may actually vary. Other studies have gone ahead and defined as a proportional change, because we know that just a variation of 3 millimeters of mercury may be a random variation. We know blood pressure varies according to Professor Kaima's talk, which has been very eloquent, that you can have quite a bit of variability of blood pressure during the day. And that variability, as he put it, confers a lot of morbidity and mortality. So 3 millimeters of mercury could just be a random variation during the day. So some studies have gone ahead to define it as a proportional change of 10% on blood pressure. So this, therefore, will mean that depending on which study you look at, as the ones I've put up, there'll be variability of the burden of salt sensitivity. Morris et al. In the first study here found salt sensitivity in blacks to be up to 79%. Those are normotensive patients. 79% were actually found to be salt sensitive, and in whites it was actually 36%. This burden actually varies whether you're looking at blacks and whites, and in main literature reports, actually salt sensitivity has been defined as the hallmark of hypertension in black population, because a large population or a large percentage of hypertensives, black hypertensive, actually have salt sensitivity. And this study by Wright et al., which defined salt sensitivity as an increase of 10 millimeters of mercury from baseline, map 10 millimeters of mercury increase, found that hypertension, hypertension was prevalent up to about 43% in normotensive blacks, but in the hypertensive, it was up to 64%. And the white population, hypertension, salt sensitivity was prevalent in 52% in the white population and 50% in the white normotensive population. So you can see a wide variability depending on the population that is studied, and also depending on the race. But what's clear from this study is that salt sensitivity is quite prevalent in blacks, not only in the hypertensives, but also in the normotensive individuals. Surprisingly, even in the normotensive individuals who are found to be salt sensitive, they've actually been found to develop hypertension during follow-up. So in the normotensive individuals who are found to be salt sensitive, they actually have increased cardiovascular disease long-term, because they actually go on to develop hypertension during the follow-up. Salt sensitivity, just like many other physiological phenomenon in in humans actually follow a normal distribution. In this study published in a Hypertension journal in 1986, in the x-axis here or y-axis here, we have the percentage of a population, and here we have the change of blood pressure during the study. The change, negative means decrease in blood pressure, and positive being increase in blood pressure. And there are two different shades: normotensives, light shades, and hypertensive being the darker shades. You can see in the normotensives, we have more of them tending towards the left of the chart, meaning they are resistant to salt loading. Resistance here was defined as less than 5 millimeters of mercury on salt loading. And the hypertensive, you see their bar charts moving towards the right, meaning they're tending towards salt sensitivity. And this particular study, the sensitivity was defined as 10 millimeters of mercury increase upon salt loading. So in the general population, we have a so-called normal distribution, where if you take a given population, a majority of them, depending on the population that you choose, may be salt sensitive, in this particular case, hypertensives, or salt resistance in normotensives. And also, this will vary in the socioeconomic group that you actually pick to study. There evidence that actually that salt sensitivity exists in humans. Of course, there's a lot of evidence. A lot of observation studies have shown that habitual ingestion of high levels of salt causes increase in blood pressure over time, and also that increase of this blood pressure leads to populational increase in prevalence of hypertension. In populations whose overall salt intake is low, hypertension tends to be very rare, and this tends to increase as urbanization takes off, and also increased sodium consumption occurs. In the sentinel studies in the Kavirondo, as you all know, there was hardly any existence of hypertension when that study was published in 1926. But as urbanization took over and there was population migration from the rural area to the urban area, the same population ended up developing hypertension when the sodium consumption actually increased. This evidence of salt sensitivity is also found in clinical trials. In this trial, DASH sodium trial, which is very popular, published in 2001 in New England Journal of Medicine, they went out to study increasing salt population, increasing salt consumption in the population, a collaborative study, big collaborative study, where the high salt intake was 8 grams per day of sodium chloride intake. The intermediate was 6 grams per day, and the low sodium intake was 4 grams per day. This translates to about 8 grams per day is about 150 millimoles of sodium in a day, 6 grams 100, and 4 grams about 50, which is defined as low sodium diet. And over time, in this particular study, we note that as patients decrease the sodium intake from 8 grams per day to 4, you can see a linear decrease in hypertension, systolic blood pressure, both systolic blood pressure and also diastolic blood pressure. And this correlated very well with the standard marker of sodium intake, which is 24-hour collection of sodium excretion. They also studied the effect of DASH diet. So controls didn't have just controlled the sodium, but didn't have DASH diet. And then there's also the arm of the DASH diet. And you can see that controlled diet, just decreasing the sodium intake, reduced systolic blood pressure from 132 to about 125. That's about 127 there, but that's 5 millimeters of mercury decrease. And when you add DASH diet, which is Mediterranean diet, diet rich in potassium, low in sodium, the blood pressure fell further by about 3-4 millimeters of mercury. So a combination of about 8 millimeters of mercury by combining low sodium diet and DASH diet. And the same was replicated in diastolic blood pressure decrease of about 4 millimeters of mercury. And as the patient decreased the sodium intake over time in this trial, their urinary sodium also decreased. And what are some of the predisposing factors to salt sensitivity in the population? There are a number of them which have been put forward. I've just picked 5 of them that you're going to look at. We know that salt sensitivity increases with age. Previously, it was thought that salt sensitivity did not actually exist below the age of 45. And indeed, beyond the age of 45, that's where we have a lot of prevalence of salt sensitivity. But more data is actually coming out that salt sensitivity is also prevalent in adolescents, especially the overweight adolescents. Studies in the US actually have shown that in adolescent white population who are salt sensitive, when they actually go ahead and lose weight and actually come to normal weight, they actually lose the salt sensitivity. So over time, age may confer salt sensitivity, but whether the age per se, the advancing age per se, confers the salt sensitivity, or it is the attendant aging of the kidney. We know that kidney also ages with age with atherosclerosis, hyperfiltration, whether it's really the aging of the kidney and the intrarenal changes in the dynamics, hemodynamics that confers the salt sensitivity, whether it's age per se, is open to question. But with age, we know that salt sensitivity actually increases. There's also a gender question. It's been shown that salt sensitivity is actually more prevalent in women in most of the trial, especially in the postmenopausal age groups. The postmenopausal age group, I think that's probably plausible because that confers vasodilatory effect by increasing nitric oxide, also has some caloric effect by causing loss of sodium. However, in terms of women having more salt sensitivity, there's been a lot of debate because in most of the trials, they did give the whole study population a fixed amount of salt in order to salt load them over a period of time before they were studied. And we know that women have a lower weight, lean body weight compared to men. Whether that actually is what caused them to be more salt sensitive is actually debatable. But in most of the trials, they actually found more women being salt sensitive than men. Body weight also been reported to confer more salt sensitivity. Obese and overweight patients are more salt sensitive, apart from having more prevalence of hypertension. And weight reduction in adolescents who are obese have actually shown to reduce salt sensitivity over time. There's been postulation that obesity actually leads to increased sympathetic discharge, which may increase salt sensitivity by stimulating the production of renin, which activates the renin-angiotensin system, thereby retaining salt, fluid overload, and developing hypertension. We also know that obesity in itself portends inflammatory milieu, interleukin-6 and all that, which has been found to also change some intrarenal dynamics that may increase the renal filtration pressure and confer salt sensitivity. Race, as I've said, the salt sensitivity is more prevalent in African Americans, and in many studies, salt sensitivity has been found to be about 70% of African Americans, and salt has been defined, salt sensitivity is so prevalent in this population that's it's been described to be the hallmark of Black hypertension. Of course, we know there's an intersection of genetics and socioeconomic contribution to this. We know that in these populations that have returned high salt sensitivity in Black Africans, they will not only have probably a genetic predisposition, but also an environmental socioeconomic push to this predisposition. For example, the diet consumed by African Americans in these particular studies was found to be high in salt and low in sodium compared to the diet that was being consumed predominantly by the white population, which was found to be slightly higher in potassium and not high in salt. Basically, most of the foods that are affordable or cheap ends up having more salt in them. What about renal insufficiency? Most of our CKD patients, as they progress, as you are shown by the previous speaker, actually have hypertension. And salt sensitivity is one of the risk factors that confers that hypertension. Renal insufficiency has been shown to alter the intrarenal dynamics, causing increase in capillary permeability, hyperfiltration, and also microalbuminuria. This has been shown to activate the renin system, and this leads to basically more retention of sodium, water, and conference of salt sensitivity. With progression of renal insufficiency, we have the reset of salt natriuresis, where if you take a fixed amount of, in this particular study, they looked at a fixed amount of urinary sodium and looked at the normotensive and hypertensive patients. As we have the renal insufficiency progressing, and increased hyperfiltration, there is progressive increase in blood pressure to be able to excrete the same amount of urinary sodium. In other words, the pressure natriuresis, the pressure that you need at level of the glomeruli to excrete a given amount of sodium, say this is 100 millimoles per liter of sodium excretion, in normotensive, you'll require a relatively low systolic blood pressure. But with changes in the glomeruli and hyperfiltration, you may require actually a higher systolic blood pressure to achieve the same. So this leads to a reset in the pressure natriuresis, meaning the pressure natriuresis actually being shifted from the left side to the right side, causing not only more damage to the kidney, but leading to a vicious cycle of more sodium being filtered and perpetuating the activation of renal angiotensin system and conferring more salt sensitivity. What about other diet? We know that salt sensitivity is conferred by sodium chloride. What about other nutrients or electrolytes? Salt sensitive subjects excrete more calcium than salt resistant subjects in their diet, and it's been shown that supplementation of calcium during normal dietary intake of sodium leads to significantly reduced blood pressure in this particular patient. And the protective effect of calcium in terms of dietary provision led to the recommendation of the JNC recommendation that recommended a low-fat dairy products as one of the components of DASH diet to reduce blood pressure. Potassium is big. Potassium has a very good effect in terms of reducing the effect of sodium sensitivity. Dietary potassium has been shown to exert a powerful and dose-dependent marker or dose-dependent effect in the effect of sodium sensitivity. A diet that's low in sodium, say 20 millimoles per liter, in trials showed 79% of normotensive patients having salt sensitivity, and 36% of this patient, 36% of the white population showing salt sensitivity. However, when this population increased the potassium intake, the salt sensitivity reduced from 79% in the black population to a mere 20%. And the salt sensitivity in white was basically abolished. If you look at this, it's presented quite well here. In the x-axis, we have the frequency of salt sensitivity in this trial. Blacks, depicted by the dark bar charts, almost 76, 78%. And this is the potassium intake, low, 30, very high salt sensitivity. As they increased the potassium intake to as high as 120, you can see the prevalence of salt sensitivity decreased to almost 20% in the blacks here, and was almost abolished completely in the whites. And you can also see the change in mean arterial pressure from low to high salt, mediated or the effect of increasing potassium intake. So in this population, as they increase their potassium intake, the change in blood pressure was actually muted from an increase of systolic blood pressure of 6 with low potassium intake. The blood pressure increase was hardly actually decreased by about 2 millimeters of mercury, and there was no change in blood pressure at all in the whites. So potassium is a very powerful, dose-dependent effect in terms of reducing salt sensitivity. I mean, this has to be taken in context. For example, those of us who treat patients who are CKD, especially advanced CKD, CKD 4 or 5, this may not apply, but for early CKD and patients who don't have CKD, potassium will be a useful addition in their diet. What about genetic basis of salt sensitivity? This is an area of intense study, but I'll just say that there's no particular gene which has been described to confer salt sensitivity. Various genes in various systems have been put forward to try explain the salt sensitivity, and these genes range from the renin angiotensin system, ions, various transporters in the kidney, sodium and water transporters, endothelial system, sympathetic system. A lot of genes have been described to predispose to salt sensitivity, but not one gene has been shown to confer all the risk. So why the interest in the genetic basis of salt sensitivity? This may actually help us further define the pathogenesis of salt sensitivity, which a lot of it actually has been done in other mammals like rats, but very good studies in humans are actually lacking. And it may also provide a point of intervention. For example, the very well-studied area of sodium and water transporters in the kidney, and they're actually very well elaborated studies in terms of gain-in-function mutations in some of the transporters in the kidney, genes conferring those gain-in-function mutations. If you're able to target those genes, then you can actually cure or modify the pathophysiology of this disease. The other area, of course, is identify biomarkers that may confer salt sensitivity. Salt sensitivity is a difficult entity to define in everyday clinical practice. You may get a direct inference of salt sensitivity by looking at 24-hour urine collection, but short of doing a protocol study of sodium loading and then sodium decrease, it's quite difficult to define salt sensitivity, and therefore its regular application in clinical practice has been a challenge. So by identifying these gene markers, if you're able to get a biomarker that defines salt sensitivity, that will make this clinical entity easily the diagnostic of practice, and therefore we can apply this in trying to make decisions about those patients who have been diagnosed to be salt sensitive. I'll look at very briefly some of the mechanisms that have been put forward in terms of trying to explain salt sensitivity. There are various mechanisms, but I'll just pick two that have been recently published. This appeared in JASN, I think 2008, where one of these molecules called RAC. RAC is a member of G protein group of proteins that's been found to confer sodium sensitivity in a lot of the Black patients. So in salt sensitive, in salt resistant populations, meaning they don't increase the blood pressure with an increase in salt, RAC protein is actually decreased with increasing salt. When RAC protein is increased, actually mediates decrease in mineralocorticoid receptor elaboration from nuclei, and therefore decreased sodium reabsorption, water reabsorption, and blood pressure remains normal. However, when they looked at the salt-sensitive population, there was actually a paradoxical increase in RAC protein in those with increased salt intake. And with the paradoxical increase in RAC protein, there was increased elaboration of mineralocorticoid receptor, which would interact independently of the aldosterone with RAC. So RAC pathway was independent of the level of aldosterone, whether it's decreased or increased. So with the interaction of RAC protein and the mineralocorticoid receptor, the blood pressure increased with, of course, increased reabsorption of sodium and water. So RAC protein gain in function or increased activity is one of those areas that have been put forward as to explain the increased salt sensitivity in the Black population. What about the sympathetic nervous system? Recently, publications have been done in the without lysine kinase mediators. Generally speaking, usually the without lysine kinase, that is WNK4, usually downregulates the sodium channels in the kidney. So in the salt-resistant individuals, if you increase your salt intake, there's decreased sympathetic nervous system activation by a decrease in renin, and that leads to increased elaboration of the without lysine kinase 4, further decreasing the sodium channel in the kidneys and therefore decreasing the pressure. However, in the salt-sensitive individual, there is a paradoxical increase in renin and sympathetic nervous system activation, which leads to decrease in without lysine kinase 4, which is normally an inhibitory mediator for the sodium channels in the kidney. The sodium chloride co-transporters, especially thiazide sensitive segment of distal tubules. So with decreasing without lysine kinase 4, there's increased elaboration of sodium channels, increased sodium retention, and salt sensitivity is actually seen. So having looked at all that, what is the importance? What is the clinical implication of salt sensitivity? Why is it important in our clinical practice? We know that sodium restriction has been shown in many clinical trials, combined with a DASH diet, reduced blood pressure, and also confer reduced cardiovascular disease and burden. The greatest response actually seen in the hypertensive patients than in the normotensive patients. Salt restriction is also recommended in various guidelines. The current US dietary guidelines actually recommend less than 2,300 milligrams of salt or lower in those without cardiovascular disease, but 1,500 milligrams of salt in those with cardiovascular disease and hypertension, combined with a DASH diet, which will be a diet rich in potassium for those without advanced CKD, a diet rich in vegetables and fruit, and Mediterranean diet. However, this is easier said than done. There's a lot of difficulty in trying to achieve, especially these low levels of salt, because people get this salt not only just adding it in their food, but in pre-processed foods. And most pre-processed foods nowadays have a lot of salt that's added actually. So this recommendation, is it just for everybody or is it just for those who are salt sensitive? I mean, the challenge here is really diagnosis of the salt sensitive population, because otherwise it will not be justified for everybody to be on this very strict low sodium diet. But in a clinical setup, it's actually quite difficult to know those who are sodium sensitive and those who are not, to be able to apply this clinical guideline, short of which it doesn't harm to apply it across the board, because it's actually also sensitive in normotensive patients. What about the antihypertensive drugs used for hypertension in salt-sensitive population? In this meta-analysis published in 2008, they looked at a comparison of various antihypertensive drugs in treatment of salt-sensitive individuals. And in this publication, looking at 25 studies in this meta-analysis, they found calcium channel blockers combined with thiazides or thiazide diuretics in a background or low or moderate salt intake to be the most optimal management of patients who are not obese but have salt-sensitive hypertension. Those who are obese, combination with metformin was even better. So in our salt-sensitive patients, it's actually better in terms of first line, putting them on calcium channel blockers plus thiazide or thiazide-like diuretics in terms of controlling their blood pressure. And this is actually also shown in this publication in New England Journal, where actually patients from Kenya were studied. This study was looking at dual therapies, that's a combination of two antihypertensive drugs in Black Africans in sub-Saharan Africa, included patients from Kenya, Zimbabwe, South Africa, and Nigeria. And in this publication of 728 Black patients with hypertension, and in my presentation, it is true that these patients, most of them would have had salt sensitivity, because up to 78% of them would be salt sensitive according to the trials we've looked at. They studied various combinations of hypertensive drugs, including amlodipine, hydrochlorothiazide, amlodipine combined with perindopril, and perindopril combined with hydrochlorothiazide in various doses of these drugs. And what they actually found was actually similar to what you've just seen in that meta-analysis, where a combination of amlodipine, the red graph there, with hydrochlorothiazide has the biggest drop in office systolic blood pressure. In this particular trial, they used office systolic blood pressure, I guess, for various reasons, but the blood pressure decreased from 160, as you can see, to the low 130s with hydrochlorothiazide amlodipine combination in the Black hypertensive patient, many of which who will be salt sensitive, followed by amlodipine perindopril combination and perindopril hydrochlorothiazide combination being at the top, being the list of these three combinations in terms of lowering the blood pressure. So I guess the takeaway in this slide is for our patients, Black, many of whom will be salt sensitive, it would be better to start them on this combination, provided the kidney function is good enough and the EGFR is less than 30. We know that below EGFR or less than 30, hydrochlorothiazide is not very efficacious. In conclusion then, salt-sensitive hypertension is a prevalent condition, being the hallmark of hypertension in Black patients. It is a genetic and environmental socioeconomic interaction in its causation, and we should actually bear in this in trying to, when you're applying this in clinical practice. And salt restriction in a background of a DASH diet, together with other lifestyle interventions, should be the baseline with which we start our hypertensive management. And calcium channel blockers combined with thiazide or thiazide-like diuretics are probably the most efficacious in managing salt-sensitive hypertension. Thank you.
Yes.
Yes, thanks, Okel. Elaborate, very excellent presentation. We take salt very lightly, but obviously what you presented, it's the big, big culprit. And the late Professor Abdallah was really, enthusiastic about this salt story. So my question is, the last slide you showed, the second last, interestingly, S inhibitors or ARBs plus thiazides are not as good in salt sensitive as amlodipine and hydrochlorothiazide. So, you would think about RAS system and blockage of the RAS system and aldosterone would actually, get rid of more salt with the thiazide rather than amlodipine. How do you explain that?
Yeah, that's actually a good question. And actually, I thought the same. And many times would think that pathophysiologically it would actually make sense that a combination of thiazide and pridopil would actually confer more advantage in salt-sensitive hypertension. But in this particular trial and many other trials in salt-sensitive hypertension, amlodipine hydrochlorothiazide combination actually is much better. I think what that tells us is probably there's much that you may not actually know in terms of explaining the salt sensitivity phenomenon.
What is low salt? How do people eat too much salt? I think we need to address this question because most of us are not crisp eaters, fast food eaters. We just eat our normal food. So where can we reduce our salt? Where do we take our salt in? Right? None of us eat maembe na pilipili na salt. So where is our excess salt if you compare it to a European diet? Totally different. But that's a subject for another day, I presume. Dr. Okel?
Yeah, I think it is. But in most trials looking at this subject, the excess salt actually comes from pre-processed foods, more than what we would add in our diet and what would actually see as salt in our food. The fast foods, the cake, the bread, all that pre-processed food probably gives us more salt intake at the end of the day than what you actually think we are adding in our food when you're preparing it.
As you understand, a salt crystal will not dissolve on meat. So you have to put a lot of it in order to taste that salt. So we need to identify these things so that people know where they're taking too much salt. I think it's a very important subject, and it's a quick win. If you can manage, you can drop your blood pressure. You don't have to swallow the tablets. I think, thank you very much for that very, very useful presentation. I think we must listen to what you have said because it's something we can do. We don't need money to do that.